Hello, and this is the first lecture on the Pituitary series. So, the topic today will be acromegaly. My name is Santosh Abraham. I'm a specialist registrar in diabetes and endocrinology at Scarborough General Hospital. So, the definition of acromegaly: it is a clinical condition where there is prolonged and excessive secretion of GH, and hence IGF secretion is also increased. So there's a blunting of pulsatile secretion of the GH secretion. That's a hallmark of this condition. So epidemiology, it's a rare tumor. It's a rare condition, but there is equal sex distribution. And prevalence is 40 to 86 cases per million population. Incidence of the new cases in the UK is 4 per million population, so it's a very, very rare case. So onset is insidious, and there's a considerable delay between the onset of clinical features and the diagnosis. So the clinical features manifest quite late, so the diagnosis also becomes quite late. So most of the cases are diagnosed at 40 to 60 years. So in older patients, it's a milder disease, and the GH levels also are lower, and the tumor size is small. Now these are the causes of acromegaly in general. Like most common causes are pituitary adenoma in more than 99% of the cases, and in that macroadenomas constitute 60 to 80%, while microadenomas are 20 to 40%. Local invasion is common, but carcinomas are very rare. So rarely you have ectopic GHRH. Due to increased GHRH secretion. So ectopic GHRH producing tumors like carcinoids or other neuroendocrine tumors. Or you have ectopic GH secretion from pancreatic islet cell tumors. So these can also cause acromegaly. And in GH secreting pituitary adenomas, GS alpha mutations are found in 40% of the tumors. So these are most commonly in young patients who have large tumors. So a family history could be important. So I will come to the genetics and the causes in more detail in the next slides. So as you can see in this slide, you can see that it could be either due to primary GH excess or extrapituitary GH excess, or it could be a GHRH excess. So all these causes somatic growth, metabolic dysfunction in general. So excess GH as a result of any of these mechanisms causes the liver to secrete more IGF1. So what are the causes of the primary GH excess? It could be a pituitary adenoma, it could be densely granulated or sparsely granulated or mixed type, which includes GH and PRL, the prolactin secreting tumors. Or it could be acidophil stem cells or plurihormonals. It could be very rarely a pituitary carcinoma. Could be from ectopic sources as well. And it could be associated with either of these: the McCune-Albright syndrome, the familial acromegaly, or the Carney complex. So when you come to extrapituitary GH excess, where GH is secreted from an extrapituitary source, usually it is from the pancreatic islet cell tumor, very rarely from lymphomas, and very, very rarely iatrogenic. How about the GHRH excess? So there are a variety of tumors, peripheral tumors, which secrete excess GHRH, including the bronchial carcinoid, pancreatic islet cell tumors, small cell lung cancer, adrenal adenoma, medullary carcinoma of thyroid, FEO, and it could be even from a hypothalamic tumor also. So all these have to be kept in mind, although the most important cause is a pituitary adenoma for acromegaly. So as you can see from this chart, the excess GH secretion is mostly from pituitary, 98%, and from the extra pituitary and the excess GHRH secretion, it's very less. So this is a very detailed chart, and you can see from this the various causes and the various the prevalence and the various clinical features and the pathology behind all these. You don't have to go into detail, as for the exam they won't be asked much. So associations, I've already told, it's the MEN1, the Carney complex, which has got activating mutations of PKA, protein kinase A, and McCune-Albright syndrome, known for the somatic mosaicism or for the GSP mutations, and familial isolated pituitary adenomas as well. So how about the physiology? GH is a hormone which is synthesized and stored in the somatotrope cells in response to inducing signals mainly from the hypothalamic GHRH. So it is suppressed by somatostatin signaling, primarily through the somatostatin receptor SST2. So peripheral signals including IGF1, steroids, paracrine growth factors also regulate GH production. So you have the somatostatin receptors, and where you could the somatostatin receptor analogs could work in these tumors. So let's come to the genetics. So there are lots of genetic mechanisms for acromegaly, but this is the most important pathway, which I've made a flowchart also along with this. So the G stimulatory proteins get mutated. So there are active mutations of there is an activating mutation of the G stimulatory protein, the GS proteins. These activating point mutations, especially of the GS alpha, activate the GS alpha protein and convert it into an oncogene called the GSP. So once GSP is formed, it increases the cyclic AMP levels. It activates protein kinase C. The CAMP will activate the protein kinase C, which in turn phosphorylates CREB. So once CREB is phosphorylated, it leads to sustained constitutive GH hypersecretion and cell proliferation. So the first step is mutation of the GS, especially the GS alpha. So it converts the G protein into the GSP or an oncogene, and the GSP increases cyclic AMP pathways in the cell, and it activates this. The CAMP activates protein kinase A, and this phosphorylates CREB, and this leads to increased GH secretion and cell proliferation. So these GSP bearing adenomas are smaller, and they do not respond briskly to GHRH and are sensitive to the inhibitory effect of somatostatin. Other signaling pathways include those for AKT and MAPK, so which I will discuss towards the end of this session about the significance of these pathways and the oncogenesis of cancers, secondary cancers in acromegaly. So this is the pathway. So GS activating mutations converts the G protein oncogene, the GSP. It increases cyclic AMP. It activates protein kinase A. So it phosphorylates CREB, and there is increased GH secretion. So other genetic mechanisms include there is they also exhibit loss of PRB expression, also abnormalities in the RB1 locus like LOH of the region 13q14. These all are associated with promoter hypermethylation. PT2 gene overexpression. This will lead to chromatid separation and cell aneuploidy, but these mutations are abundant in all pituitary tumor types, but they have not been identified in pituitary tumors, so they are not very significant. But the loss of PRB seems to be quite significant, and in case of METs, they exhibit LOH of the region, LOH of the RB1 locus. Another proposed mechanism is allelic imbalance at the CCND1 locus encoding cyclin D1. So it is found in non-functioning pituitary adenomas. So the cyclins D1, D2, D3, they are upregulated when quiescent cells, that is non-dividing cells, enter the cell cycle, and CDKs complexes lead to PRB phosphorylation and releasing ETF to promote cell cycle progression. So when there is an imbalance which results in a faulty encoding of the cyclin D1, it could result in a non-functioning pituitary adenoma. Another factor, basic FGF or FGF2, has also been implicated, but it's not been proved. But FGF2 expression is found to be increased. Prolactinomas express more of FGF4. And the FGF4 can increase PRL secretion and tumor vascularity. So the main point here is the CCND1 locus, which becomes, the alleles become imbalanced there. So it could be implicated in non-functioning pituitary adenomas. EGF and its receptor EGFR are overexpressed in pituitary tumors, particularly in ACTH secreting and non-functioning adenomas. So EGF and EGFR overexpression in ACTH secreting and non-functioning adenomas are implicated. Another one is HMGA2 overexpression in pituitary adenomas. So the HMGA2, the importance is that it correlates with the tumor size, invasiveness, and proliferation markers. So the tumorigenesis could be mediated by inducing cyclin B2 expression and activating the E2F pathway. So recent surveys indicate that there is an increase in acromegaly in the annual incidence to about 10 cases per million. That's all over the world. So GH and IGF1 act both independently and dependently to induce features of hypersomatotropism, which I will explain towards the end of this presentation. So over 95% of patients with acromegaly harbor a GH secreting pituitary adenoma, which I've already told you before. So histopathology, they include these GH secreting adenomas. They are of two types: densely granulated or sparsely granulated somatotropic tumors. So sparsely granulated tumors are more common in younger patients and they are more aggressive. But densely granulated tumors are smaller and are more biochemically active. Then there are mixed tumors that and mammosomatotropic tumors which could co-secrete GH and prolactin. So monomorphous acidophilic stem cell adenomas, they're rare, but they arise from the common GH and PRL stem cells, and they contain giant mitochondria and misplaced GH granules which are exocytosed. So they grow rapidly and are invasive. So what about the colonic neoplasms and other GI neoplasms? So the prevalence of colonic GI neoplasms or polyps was the colonic polyps was 32%. So higher IGF1 levels at diagnosis are associated with distal colon lesions. Hypertrophic mucosal folds and colonic hypertrophy as well as diverticulae are commonly seen. There is an increased incidence of gallbladder polyps as well, and benign prostate hypertrophy has also been reported. Incidence of colorectal, kidney and thyroid cancers appears to be the most significantly elevated in acromegaly. Acromegaly as well as other tumors of pituitary. So familial isolated pituitary adenomas. These are existence of 2 or more cases of acromegaly or gigantism. So 2 or more cases of acromegaly that does not feature Men or Carney complex. So people who have a family history of 2 or more cases of acromegaly, excluding Men1 or Carney, they're autosomal dominant. They, most of them have acromegaly, and 30 to 50% cases have a mutation in the AIP gene. It's a tumor suppressor gene. And familial isolated pituitary adenomas have an early onset. They're present before 30 years usually, and they got a poor response to somatostatin analogs. So in a patient who is below 30 years of age, consider screening for AIP and also take a careful family history. So that is a takeaway point from this slide. So what about the morbidity and mortality with acromegaly? So as you all know, cardiovascular disease is the leading cause, followed by respiratory, because they most of them have the obstructive sleep apnea and pharyngeal and thickening and macroglossia, and followed by cerebrovascular disease. The incidence of stroke also increases. So what are the most important mortality determinants? So the most important are GH levels greater than 2.5 microgram per liter, elevated IGF1 levels, and if there is any hypertension or heart disease, age. As you age, the mortality increases. Any history of radiation, or if the ACTH, if there is an over replacement in the adrenal insufficiency. So if the GH levels are below 2.5 microgram per liter with normal IGF1, it is associated with significant reductions of morbidity and mortality. So the investigation of acromegaly, as you all know, OGTT is the gold standard. So failure to suppress GH to less than 0.33 micrograms per liter to a 75 oral glucose load. In contrast, normally GH is suppressed to undetectable levels. So false positives can happen in chronic liver failure, chronic renal failure, malnutrition, diabetes mellitus, random GH. It's not useful in the diagnosis of acromegaly. But in untreated patients, random GH less than 0.33 practically excludes the diagnosis. So IGF1, it's the screening test. So it differentiates patients with acromegaly from normals. So it's mostly elevated in acromegaly, except in some other conditions. So it has a long half-life. MRI is used to demonstrate the tumor, extracellular extension, supracellular or into the cavernous sinus. So that's important for the MRI, not only to detect the tumor but the extension of the tumor also. Some of the patients have hypercalciuric, as GH stimulates 1-alpha hydroxylase. So they could have probably an increased incidence of renal stones due to hypercalcemia as well as hypercalciuria. Rarely, hypercalcemia can also be associated with the Men1 and hyperparathyroidism. So, in some cases, it is not possible to demonstrate a pituitary tumor, or the pituitary gland MRI does not reveal any enlargement, and the histology is normal. In that case, a serum GHRH needs to be taken, and also a CT of the abdomen and the chest to identify if there is any extra source of GHRH secreting tumor is there. It's like you have a GHRH secreting tumor of the lung, mainly the carcinoid or of the pancreas. So GHDC, day curve, it's not a very common test. So GH is taken at 4 to 5 time points during a single day. So it is mainly used to assess response to treatment following surgery or radiotherapy, and also to assess GH suppression on somatostatin analogs. It does not have a role in the diagnosis of acromegaly. The GH reference preparation should be a recombinant 22 kilodalton HGH. So for the exam purposes, you can just remember that. There is no acceptable IGF1 reference preparation as of now. So management. So transfemoral surgery is usually the first line. It cures 40 to 90% of microadenomas and 10 to 48% of macroadenomas. Say growth hormone. So the GHDC should be performed following the surgery to assess the safe levels of GH and IGF1 have been attained. So from the GHDC, you have the from the growth hormone day curve, you have the you look for the mean GH. So if it is less than 2.5 micrograms per liter, then the patient can be followed with annual IGF1 and GH assessment. But if it is not the case, then medical therapy and medical treatment and radiotherapy is indicated. So in the case of a large microadenoma, even if cure is not expected, surgical debulking should be taken, because it lowers the GH levels and improves the cure rate with subsequent medical therapy. So tumor recurrence, this is defined as tumor regrowth and increase in GH levels. So again, the acromegaly becomes active. So the definition, using this definition, based on the mean GH less than 2.5, the reported recurrence rate is low, 6% at 5 years. So radiotherapy, it's indicated following unsuccessful transfemoral surgery, rarely as a primary therapy. So the largest fall in the GH occurs during the first 2 years, but still the GH falls after this. The normalization of mean GH may take several years. So you need to have adjunctive medical treatment along with this. So the distribution is as follows. Like if the starting mean GH is more than 25, it takes average 6 years to achieve the mean to less than 2.5. But if it is less than 25, the starting mean, it takes 4 years. So the baseline GH is very important to have a fall in terms of the time scale. So after radiotherapy, somatostatin analogs should be withdrawn on an annual basis to perform a growth hormone day curve to assess progress and identify when the GH is less than 2.5. So after radiotherapy, the medications can be gradually withdrawn to look whether the GH, the mean GH, has fallen below less than 2.5. Another problem with radiotherapy is that it can induce GH deficiency, and then the patient might need subsequent GH therapy. So somatostatin analogs, they lead to suppression of GH secretion in 20 to 60% of patients. So 40% of the patients are complete responders, and it will lead to normalization of GH that is less than 2.5 and IGF1 levels. Some of them are partial responders, so they will not suppress the GH despite dose escalation. I mean, it will not work in them. So how is the response to the drug assessed? So you measure the GH at hourly intervals for 6 hours following the injection of 50 to 100 micrograms of octreotide subcutaneously. So this also predicts the long-term response. So you have octreotide and a novel analog, lanreotide. So octreotide long-acting type LR 20 mg is administered every 4 weeks, and then you could alter the dose. Lanreotide autogel 90 mg deep subcutaneously is also administered every month, so the dose also can be altered. So with the subcutaneous administration is that the patients can be taught to self-administer the lanreotide. So these are used as a primary therapy when the tumor does not cause mass effects, or in the patients who have received surgery and or radiotherapy who have mean elevated GH. So the somatostatin analogs are used in them who have failed surgery or who have undergone surgery and plus radiotherapy, but the mean GH is still elevated. So pasuretide is a new analog, so it stimulates SST2 and SST5 simultaneously. So it may increase the response rate in patients with acromegaly. But glucose tolerance declines and the patients may develop diabetes with pasuretide. That is important and that needs to be borne in mind. So dopamine agonists, they are now less frequently used. They do lead to lowering of GH, but the normalization of GH doesn't happen. Also, if there is coexistent secretion of prolactin, this might be helpful, and in these cases even the tumor can shrink. So carbagalin has been shown to be more effective than bromocriptine, and it may even normalize the IGF1 in up to 30%. And a lower pretreatment IGF1 favors a good response. So if the IGF1 before the treatment is low, it could have these tumors could respond better and have a good response to dopamine agonists. So the GH receptor antagonists. So if these patients with acromegaly do not respond to somatostatin, then pegvisomant can be used. So LFTs should be monitored every 6 weeks for 6 months. Pegvisomant also can cause an increase in the pituitary size, so 6-monthly MRI is indicated. It could be co-administered with octreotide or lanreotide to decrease the frequency of these pegvisomant injections because it's daily. So in short, this is how this is managed. So whether you find whether it's a microadenoma or macroadenoma. So in microadenoma, if the GH is with the surgery, if the GH falls below, the mean GH falls below 2.5, and IGF1 also normalizes, which happens in 90% of the cases, no need of any follow-up or treatment. But in macroadenoma also, if the GH falls below 2.5 and if the IGF1 is normal in 45% cases, no need of any further treatment. But in both the cases, if the GH is more than 2.5, the mean GH, and the IGF1 is also high, you go for the medical treatment. First with somatostatin analogs. If you cannot use them, you use the dopamine analogs. And if they don't respond, you could use the pegvisomant. And then still, if the GH is not getting suppressed and the IGF1 is high, external beam radiotherapy. But if the GH is less than 2.5, you could consider external beam radiotherapy, but you do the external beam radiotherapy if the GH is still high and the IGF1 is also high. So IGF1 mechanism of action. So it binds to at least 2 receptors. So these are tyrosine kinases. So the IGF1 receptor and the insulin receptor. So one is the IGF1 receptor and the other one is the insulin receptor. So primary action is mediated through the IGF1R. So it initiates intracellular signaling. And IGF1 is one of the most potent natural activators of the Akt signaling pathway. So it stimulates cell growth, proliferation, and it also inhibits apoptosis. And this is the physiological receptor for the IGF because it binds IGF1 with significant affinity than insulin receptor. So I told you about the Akt pathway because IGF1 when it binds to IGF1R, it activates the Akt pathway. So Akt is a serine threonine specific protein kinase. So it has multiple roles in glucose metabolism, apoptosis, cell proliferation, transcription, and cell migration. So IGF1R, the receptor, has a critical role. It modulates the metabolic effects of IGF1 for cellular senescence and survival. Also, it in a local level, it is called a paracrine. It exhibits paracrine activity. So after the IGF1R is activated, there is intracellular signaling, and it occurs through a magnitude of signaling pathways. So the most important pathway is the AKI PI3K mTOR pathway. Sorry, AKT PI3K mTOR pathway, which I will explain the next slide. So the PI3 AKT mTOR pathway, it's an intracellular signaling pathway. It is important in regulating the cell cycle. So it's related to cellular quiescence, proliferation, cancer, and longevity. So P13 activates and phosphorylates, by phosphorylation it activates AKT. So AKT will activate CREB. Also it inhibits P27. It activates mTOR. And mTOR will affect transcription of P70 or 4-EBP1. So the factors which enhance this pathway are the epidermal growth factor, the insulin-like growth factor, the SHH, insulin, and CAM. Even the leptin and insulin recruit more P13K for metabolic regulation. It is antagonized by P10, GSK3B, and HP9. So P10 is very important. So why I explained all these pathways is because you find a lot of secondary cancers or new cancers, increasing in acromegaly. So as I've told, what is the reason for this increased incidence of cancer? So it could be due to the effect of GH, and it could also be due to the effect of IGF1, which I've explained what happens when the IGF1 binds with the IGF1R. So how about GH? So GH, when it binds with the GH receptor, it activates signal transduction for it is important for the cell growth and survival. So it mainly activates the JAK2 STAT pathway and the CSRC. So it's a MAPK pathway. So and the PI3K also, like the IGF. So upregulation of components of these pathways has been found in lots of malignancies. So it also GH also induces early response genes, so which will activate cell growth and differentiation signals, which are mediated by CCAT. So it will also GH also will induce early response genes, which will activate cell growth and differentiation. So CH and IGF1 also has been shown, GH and IGF1 also has been shown to have anti-apoptotic properties in several cell lines, including human colonic adenocarcinoma. So here lies the importance. In fact, most of the studies on colonic carcinomas and other carcinomas developing acromegaly have shown that these pathways are actually upregulated. So possibly these could be asked in the SE exam. So that's why I have included it as a in the final part. So it is better to have some understanding about tumorigenesis and the various pathways. Thank you.